Care that is person-centered takes into consideration patients' personal preferences, needs, values, their family situations, cultural traditions, and their lifestyles, ensuring that what matters most to patients guides all clinical decisions. How can we move towards a more person-centered healthcare system? This is episode 12 of Pep Talks, the Patient Engagement Podcast. In this episode, recorded in summer of 2020, we speak to Kimberly Manilili about the importance of quality indicators to capture and measure what matters most to patients, families, and communities to achieve a more person-centered care approach to care. Paul Ferry first asked Kimberly to share with us how COVID-19 has affected her work.
It's certainly impacted my work. I would say in that, that first week, I just couldn't focus.
Mm-hmm.
I was I think maybe it's just having, the public health background, but maybe even for others without a public health background, just sort of obsession with the news and some of the data that was coming out. And it was, kind of worrisome, but also just really interesting. And I think just the disruption too of my normal routine. I really like to go into work.
Mm-hmm.
I like to see people, even if I don't work with them.
Mm-hmm.
I just like to interact with people and kind of have that as a break in my day.
Mm-hmm.
And so kind of losing some of that routine. I don't know. It just really affected my ability to just kind of sit there and, to read and write. And I'm working on a systematic review right now. And so it's just screening abstracts,
Mm-hmm.
just something that's, can be really tedious, but I just couldn't do it.
Do you think there's any particular impacts for people doing patient engagement or patient-oriented research during this time?
Right. So for people doing patient engagement research and patient-oriented research, just that, that inability to get together. For me, so much of patient engaged research is just very relational. And there is something about, having video calls and phone calls and touching base by email, but just a lot of that relationship building happens in person. And that's definitely been my experience in working with patients and community members is, you get together, even in the evenings or weekends to do research and to reach out to other people and to not be able to have that that kind of personal interaction in that way, I think is really limiting.
Mm-hmm.
Yeah. And I know some colleagues that, they're doing research with patients. And so they've had to put a stop to their research right now, or just things are on hold and just sort of focusing on other things for the time being.
Mm-hmm. Any other thoughts about COVID-19 and your work?
I think, I don't know if this is really relevant, but, so living with my spouse and just trying to share space has been so interesting. And, when you go to work and you do your thing during the day, you're syncing your routines isn't as important.
Mm-hmm.
I think it's just it's a little bit harder for us to kind of figure out that rhythm and who's going to take the call from where and how do I turn this coffee table into a desk.
And
it's all those kind of funny things about working together.
I saw some pretty amusing tweets about people were listening to their spouse over the phone. And they're like, "Oh, I didn't realize my spouse was let's circle back on to this in a few weeks kind of guy."
Yeah.
So, what is patient-centered care, and how did you become interested in studying it?
Okay, so patient-centered care. There are a lot of definitions out there. We've even done this review, just kind of taking a look at how people think about it.
Mm-hmm.
Probably one of the most popular definitions is from the Institute of Medicine in 2001, where it's they define patient-centered care as care that is respective and responsive of preferences of patient preferences, needs, and values, which I think is a pretty good definition. But I know with our research team and just working with the principal investigator, Dr. Maria Santana, we've really just been kind of, advocating for more of an emphasis on person-centered care as opposed to patient-centered care. So it's really this idea of, not being so focused on the patient identity. Like people are so much more than their illness and their disease. And the idea of person-centeredness really kind of looks at people more holistically. I know in terms of my own background in public health that, like even like the social determinants of health are quite important. And so it's not even just about like the experience of the disease itself, but how other aspects of your life really like affect your quality of life, and even, the likelihood that you might experience disease differently. Yeah, so our team is really interested in this idea of person-centeredness. And for me, that really resonated with me, I think, because of my background, but it's also that I really do believe that anybody should have access to care that, confirms their dignity and confirms that they have value and that their voice is important. And so I think that that's what really attracted me to this type of research. And it's been a lot of fun. I've been working in this area for, I think it's been almost 5 years now.
Okay.
Yeah.
So your major project has involved developing these person-centered quality indicators. Tell me all about this project.
Right. Yeah. So I've been working on this with Dr. Maria Santana, who's leading this research on developing person-centered quality indicators. And it's really trying to develop these metrics that are informed by the patient perspective. Yeah. So traditionally, healthcare systems, they usually measure the quality of care based on the perspectives of the healthcare system. So that is, the clinicians, it's quality improvement managers, and it's also policymakers. So usually the quality of care is being evaluated by, people that are important and that their perspectives really are necessary to improve the quality of care. But they tend to leave out the perspective of patients who are, they receive care, that they interact with the healthcare system. So the idea of these indicators is to really reflect what matters most to patients and their families.
So what sort of work did this involve then? Like what were some of the steps that you took to involve patient partners in this work?
Right. So this research, we've been working on it for a long time. It started in 2015. We applied for multiple grants. And thankfully, we were able to get a grant from the Canadian Institutes for Health Research in the last couple of years to develop these indicators. And so these indicators, it was really, the development was a multi-year process, and where we've been able to engage patients throughout the whole process, including the engagement of patient partners, like our colleague, Sandra Zielinski, who's been really instrumental throughout the whole project, from inception, but also through, carrying out our data collection, doing the research, and also doing, helping us to interpret the data and to present it at the different stages. And so the first stage of our research was really looking to identify what indicators are out there already. And so through this phase, we did a scoping review of the literature just to see what indicators are being used, how are they being used, We also did an environmental scan. So it was a survey across Canada with different leads of regional healthcare authorities, as well as some representatives, just sort of like a sample internationally. So, we surveyed people from England, Sweden, Australia, and New Zealand as well, to get a sense of what indicators are already being used. So for the scoping review, we actually had one of our patient partners who is involved in the review and was helping to identify sources, particularly in the gray literature, around what might be important to measure from the patient perspective. And we also engaged some of our community partners, where we did sort of like this sub-study that was part of the scoping review, to look at what kinds of person-centered measures would relate to cultural competency or aspects of cultural humility. And so we also involved some of our community members to take a look at some of those, to look at some of the articles and different resources that we were able to find through that review. We conducted focus group discussions, and we did this, it was quite a patient and community engaged research project. So one of the objectives of this research was not only to get a sense from patients themselves about what matters most to them in terms of their healthcare. Like we also wanted to take this opportunity to really reach out to different communities and groups of people that aren't necessarily always represented in research. And so it was really important for us to obtain a diverse perspective. And one of the ways that we did that was we partnered with a community-based organization called Action Dignity. So formerly they were known as the Ethnocultural Council of Calgary. And so through this partnership, we were able to identify 6 people from different communities. And so we identified somebody from the Latino Hispanic community, from the African community, from Filipino, Chinese, South Asian, and Syrian communities. We're really looking at engaging some of those communities that some of them were quite well established in Calgary, and some are kind of more emerging communities where we're starting to see more people coming from those parts of the world. And normally you don't have a lot of like racialized and ethnocultural communities that are able to be part of research, for various reasons and various challenges, including like language barriers, not that much familiarity with the healthcare system and the systems here in Calgary in Canada, as well as just sort of like, maybe just some differences in cultural understanding. And there are some like economic and financial barriers as well that especially some newcomer communities might experience, like in needing to work more than one job, right?
Yeah.
And so the idea of engaging these community-based researchers was to be able to reach out to these communities, to have that link, to really act as, community brokers, in the sense that, they have these established relationships, that they're able to speak, the language, that they share culture, that, like they are able to reach out to people that, as researchers that are, based out of the university, that we don't necessarily have, that reach and those relationships to kind of, like get some of that information from people, to get some of that really rich data. that would help us get a good understanding of what matters to different communities in their care. And so we actually, this process of 6 months where we conducted training with this organization that was partnering with us. And together we are able to, train these community researchers in qualitative methods. And, we designed the study together. We developed questions. These researchers collected the data themselves and transcribed it. And then they helped with the interpretation and in presenting this data. And so in parallel to this, I know that, so we have engaged, diverse communities, but we also wanted to ensure that we reached out to other patients and caregivers. And we had another partnership actually with Alberta Health Services in doing these focus groups where we partnered with their patient and family advisory group.
Yes, yeah.
And so that group, has more than 30 representatives. And so we were able to also do focus group conversations with them to, as they, represent a number of different communities in Alberta, including rural communities. There was a couple of members of the indigenous communities, and there was also members of the LGBTQ plus community as well. And it was, with our focus groups, we were able to get really a diversity of perspectives and also a diverse range in ages, which was really great to see. We had people that were 18 taking part in our focus groups, and then people that were 80. It was really cool. Yeah. And I think one of the best outcomes from this, you have your research outcomes of, getting the data that you need. We have these experiences that help us really understand what we need to be measuring in terms of person-centered care. But just the level of engagement where people were so enthusiastic, our partners were just excited about sharing their experiences and also to do something with this data. We had this forum on, I think it's going to be 3 years ago. It was in March in 2017. We held a provincial forum where we had Verna Yu, the CEO of AHS, who was present. We also had representation from Alberta Health and just all these stakeholders across the province who were, listening to our patient and community partners talk about what they learned from this research and really advocate for doing something about it. So, this data was being used to inform the indicators, but this data was also really telling the healthcare system, we can do something about these things now. There was things that came up about, language barriers and, just having the ears of some of our leaders being like, okay, maybe we need to really improve in this area and this is how we can do it. And so there's this great opportunity to really influence change, I think, which is sort of kind of this side thing that happened, which maybe wasn't intended at the outset, but just engaging our community and patient partners that, they wanted to do something. And they, it kind of inadvertently became, this participatory action research, which I think is really one of the exciting things about partnering with patients and communities. They're like, this is all fine and great that you're doing research and something's going to come out of this in 5 or 10 years, but let's do something now.
Yeah.
So I think that was just, I think, we did this research 3 years ago, and it's still definitely something that inspires me and ignites me, I think, as a researcher. So the things that I want to keep doing is, I want to keep working with patients and community members. Like, they're just so inspiring.
Yeah. I want to talk a little bit more about community engagement approaches with patient engagement. So sometimes here at the Alberta SPORE Patient Engagement Platform, we have researchers who are interested in breaking out from beyond maybe a traditional patient research partner relationship to engage kind of a broader community. What advice would you have for researchers who wanted to do this for the first time?
Right. And I think that that's great, actually. I've gotten some questions about that in my presentations. There's so many community organizations that are already doing great work. Like, you have organizations like Action Dignity that, like, they do community-based research, but, you also have other organizations like some of the immigrant serving agencies or some of the community resource centers that, they have these relationships already with people. And I think that, it's just such a great opportunity to partner with them. But I think it's really important for researchers to recognize that they are not the priority. Mm-hmm. And, that these organizations, like, we have to really respect their time and, what they are able to contribute in the partnership. I have some nonprofit experience, and so, I'm especially advocating for, ensuring that your partners are given a budget. Like, I remember just sort of like working for a nonprofit, and you have people approaching you and wanting to partner, but it's sort of with this expectation that you'll just kind of add something new to your plate.
Yeah.
And, a lot of people in these organizations are already stretched so thin. Like, you're working with limited budgets, but, also, like, in terms of your resources, and there's so much passion with these organizations that,
Mm-hmm.
People that work for them are already kind of working like flat out in so many cases. Their weekends and evenings are already doing community work. And so for me, it's just sort of like a fairness, and it's a way of saying we are partners by, compensating people fairly, by working with them on the budget, seeing like, what do you need to be able to really partner on this research. And I think it's also an issue in terms of our funders, and whether, and I know that things are changing, and they're starting to allow for budgets to reflect that, and the need to really compensate patients and community members fairly. But I think apart from even just, that compensation, it's really developing that memorandum of understanding together, and having that as really like a co-created agreement, that it doesn't, it's not just about participating this kind of one time, but that there's sort of this plan for sustained and continued engagement, and really looking at what kinds of ways can we engage our partners in a meaningful way. So it's not just, they're going to collect data for me or find these people for me, but it's really involving them in terms of like the dissemination, and, giving the credit where it's due, and even sort of like having these, I don't know, maybe these opportunities where we could, build mutual capacity. So I really think that, we learn from our patients and community members, and if we could support them with any skill development that might help them, I think that would be great. Like, training and research or doing presentations, I think there's a real learning opportunity on both ends.
Mm-hmm. I guess one final question about how have you found the experience of building in patient engagement and the principles of patient-oriented research into your PhD project. Has it been pretty feasible? Is there any other advice you'd give to people who were interested in doing that as part of their graduate training?
Right. Yeah. So I think I'm quite lucky to be part of a research team that is so focused on patient-oriented research and patient engagement that, we have patient partners, and, we have these partnerships with community organizations and with patients that are already established. And so with my particular PhD project, where, we have developed these indicators, and my PhD is really looking at trying to understand how we could implement these indicators effectively using, theory and evidence.
Mm.
But throughout the process, even though it doesn't have a big, patient engagement kind of focus, I've been able to draw on, the expertise of our partners and our colleagues from these community and patient organizations. And so even when I'm, developing questions that are intended for clinicians, I, was able to call up Sandra Zielinski and
Yeah.
and we just chatted about it. And, because of her experience with the healthcare system, and making sure that even though I'm asking clinicians these questions about their experience, that it still will, kind of get to, how do we involve patients, meaningfully in this conversation. So, I'm talking with clinicians about, what kinds of challenges that they might see in implementing, or even what kinds of opportunities they see with implementing these indicators. But I also want to bring to the forefront that, we have to think about, what might work for patients. How are we going to engage patients? Do we see patients as, an important voice in quality improvement? Because that's really foundational for this work.
Mm-hmm.
And so I've just had these opportunities where I can, get input from patients, and as well, part of my research will be, this co-design of strategies to implement in primary care. And I don't think I could do that without patients.
Yeah.
And so part of my work will be partnering with the patient advisory, who, they provide some advice to the quality improvement team at the clinic that I'll be working with. And it's, I really want to get a sense from them, like, how do we, like, from the patient perspective, how is this going to work? If we have these indicators that will measure person-centered care, we definitely need patients to be able to, complete these surveys. And we want to be collecting their data, but what kinds of issues do you see in doing that? And so I think we can really only get that from the patients themselves.
Could you tell me about how you involve patients in the consensus process for the PCQI project?
Right. So the consensus process was really, so it was the phase of the project where, once we've identified all of these indicators, based on all of those, based on the scoping review, the environmental scan, and the focus groups and interviews, we took this initial set of 39 indicators, which is a lot of indicators, and we use a consensus process to really try and refine and prioritize the indicators. And so the consensus method we used was a modified Delphi. And with this process, it's usual that you would tap into the expertise of people in that content area. And typically, we ask people, we ask clinicians, we'll ask quality improvement people, we'll ask researchers, and sometimes patients are involved, but occasionally it's just, so sometimes we ask patients to be involved, but it tends to be maybe like one or two. which is sort of, really tokenistic.
Mm-hmm.
And so our study strived to really have half representation of patients and family and community members. And so our consensus group was experts from different perspectives, where we had 15 patients, community members, and caregivers, and then we had 15 other experts that were that had the expertise of quality improvement, that had that clinical experience, or they had that policy perspective. And so, together we went through this consensus process over a period of a few months, where we did some remote rating, but we also had a 2-day face-to-face meeting. And it was really quite the experience, where, we had one of our patient partners and one of the researchers working with us who were facilitating the process. And it was just, I think, really interesting for everybody. And I know some of the feedback we got later was just how rich and how valuable that conversation was, especially because we had so many patient voices. And I know that we had one of our colleagues who's a quality improvement expert in Ontario, who actually said that, she kind of came in at first and was really concerned about, measuring some of these things that are challenging to measure. Like, how do you measure compassionate care, or some of the challenges with measuring cost of care? But she said that after that meeting, like, she totally changed her mind, because she had no idea that these indicators were developed because patients said that was important to them. And so, she felt like just having that patient perspective, changed the way that she thought about measurement. And that maybe, even though something is hard to measure, that if it's important to measure, we should do it.
Thanks so much for joining us today.
All right. Thanks, Paul.
Thanks so much for joining us for this episode of Pep Talks, the Patient Engagement Podcast, brought to you by the Alberta Strategy for Patient-Oriented Research Patient Engagement Team. Special thanks to Paul Ferry, Sadia Ahmed, and Sandra Zielinski, and our summer students Sarah, Sydney, and Stella for their co-production. Make sure to subscribe to this podcast wherever you found it, and we hope you'll join us again for more interesting discussions about patient engagement in health research and healthcare.